Live from Atlanta, Georgia, I'm Emilio Madrigal. Today we are excited to host the world-renowned pancreatic cancer pathology expert, Dr. Ralph Hruban, who is in Baltimore, Maryland at Johns Hopkins, and will present on ductal adenocarcinomas of the pancreas. Dr. Hruban is the Baxley Professor and Director of the Department of Pathology. He also serves as Director of the Sol Goldman Pancreatic Cancer Research Center at Johns Hopkins and is a member of the Johns Hopkins Kimmel Cancer Center. I want to quickly mention the Pathology Education for Clinicians website from the Department of Pathology at Johns Hopkins, which offers numerous educational opportunities, including their famous unknown case conferences, a few iPad applications, including the great Atlas of Pancreatic Pathology app that recently came out, in which Dr. Hruban is an author and an editor as well. And you can even find links to previous PathCats on their site. And while there, please make sure to join their email list to learn about new pathology iPad apps, podcasts, and other websites, along with other educational materials offered by the Johns Hopkins Department of Pathology. I also want to extend a warm welcome for those of you who have previously joined our sessions. And for first-time viewers, Pathcast is a platform to disseminate the pathology knowledge base near and far that was started and still maintained by my good friend and colleague, Rifat Manan, and myself. As always, you're more than welcome to ask questions by typing them as comments right here in the Facebook Live and YouTube watch windows, and I will make sure to pass those questions along to Dr. Hruban at the end of the session. So with that, I will now turn the microphone over to Dr. Hruban.
Well, thank you, Rifat and Emilio. It's such a real honor and privilege to be here today. And I just love what you guys have done with Facebook and YouTube, taking wonderful advantage of these new technologies to spread information and knowledge about pathology. It's a pleasure to give a talk on tumors of the pancreas. And what I thought I'd do is focus on a very narrow area, but probably one of the most important differentials in pancreas pathology. And that's the distinction between benign reactive glands of chronic pancreatitis and infiltrating ductal adenocarcinoma. On the surface, this sounds like it must be easy. You have a benign process and one of the deadliest of all cancers, pancreatic cancer. But it's such a paradox that this such a deadly cancer can so closely mimic a benign process under the microscope. So it's a critically important distinction: benign reactive glands and invasive ductal adenocarcinoma, and yet it can be very challenging. Because it's so important, I think it's important that we should use well-defined histologic criteria. And the 8 or so I'd like to go over this afternoon are haphazard arrangement of the glands. These are features that suggest pancreatic cancer, vascular invasion, perineal invasion, intraluminal necrosis, incomplete lumina, the 4-to-1 rule, a gland next to a muscular vessel, and then SMAD4 loss on immunohistochemical stains. There are other features such as mitoses, particularly atypical mitoses, and prominent nucleoli that can be also used. But for purposes of brevity, I'll try and focus on these 8 features that can suggest ductal adenocarcinoma. What we can do is start by looking at benign pancreata. And so here's an example of chronic pancreatitis. Let's look at the slide, and you can see the features I spoke about are absent here. So at very low magnification, one appreciates the lobular units are intact. And if you think of the pancreas, think of grapes on a vine. Normally very abundant large grapes back to back. In chronic pancreatitis, the grapes shrivel, they become raisins, if you will, but the architecture still remains, this wonderful regular branching network. And we see that here with a nice lobular unit. Notice that the muscular vessels are outside of the normal lobular unit as shown here. So nice normal arrangement of the lobules are maintained in chronic pancreatitis. The other features we spoke about, again, were a gland next to a muscular vessel. So here you see a muscular vessel and the glands are far apart. They're not immediately adjacent. At higher magnification, let's look, and this is again benign chronic pancreatitis, at one of these benign glands. And one can appreciate here the features we talked about that suggest cancer are absent. The 4-to-1 rule, in which a nucleus varies by more than 4-to-1 in a given duct. Clearly, we don't see that here, and I'll go up one more magnification so you can see the nuclear features perhaps a little bit better. Again, nice uniform nuclei in this reactive gland. So we don't see the 4-to-1 rule at all here. It's kind of a 1-to-1 in this area. We don't see vascular invasion. This is in the center of a lobule. We don't see perineural invasion. We don't see any luminal necrosis, nice clean lumina. We have a complete lumen, which means that the lumen is lined completely by epithelial cells. One can appreciate here that there's a mitotic figure, and this is a benign gland, and that's why mitoses aren't that useful a feature in distinguishing benign from malignant. So, very nice example of chronic pancreatitis, and we can see that the features we spoke about that indicate adenocarcinoma are not present here. And I'm just going to scoot around at relatively low magnification, and it gives you a nice sense that even though there's all of this fibrosis, all of this atrophy, loss of parenchymal cells, one still maintains a very nice lobular architecture to the pancreas. And again, even though there's all of this fibrosis and atrophy, the muscular vessels are far away from the glands. So this is and here you can see there's a nerve, but there's no perineural invasion. There's a gland near a nerve, but perineural invasion is not present. So chronic pancreatitis compared to ductal adenocarcinoma. So those are the features of chronic pancreatitis. And now let's start going through one by one the 8 features that we talked about that support the diagnosis of pancreatic cancer. The first we mentioned was a haphazard arrangement of the glands. And so I'm going to go to low power, and this is a case of pancreatic cancer, and we'll see if we can identify what we're talking about, a haphazard arrangement of the glands. Sorry for the dirt on the slide, but one can immediately appreciate at low power that in this case you've got some glands going this way, some glands going that way, some going this way, and so on. If we go to higher magnification, there's no rhyme or reason to the organization at low power of these glands, right? They're going all sorts of different ways. And right away, I'm sure you picked up there's tons of luminal necrosis in this particular case. Pick a different case, one that may be perhaps not quite so obvious, a little poorer, not as well stained, I apologize, but one can appreciate at low magnification. It looks like these glands are randomly distributed on this microscopic slide. So the haphazard arrangement of glands is a very typical feature of ductal adenocarcinoma. Trying to find another area. Again here, adenocarcinoma, one gland going in one direction, the other in another. We've lost that beautiful lobular arrangement of the glands. So the first feature that we find so helpful, haphazard arrangement of the glands. The next, and perhaps the most obvious, is vascular invasion. Obviously, benign things don't invade vessels, and so the identification of vascular invasion is strongly supportive of a diagnosis of pancreatic cancer. Here we can see an example of chronic pancreatitis, nice lobular arrangement of the glands. And as we move around in this case, we're going to try and identify features to support the diagnosis of adenocarcinoma. And here, fortunately, we have dots that help us. Going down to higher magnification. Here. And this gets really hard because if we look at the individual gland here, you say, boy, this looks pretty benign, right? Relatively uniform cells, not much atypia, no luminal necrosis, no incomplete lumina, and I'll show you more examples of this. This is perhaps the most subtle, but believe it or not, this is in a small venule. There's some subtle muscle here on the outside. This is an invasive adenocarcinoma of the pancreas where it doesn't belong, in the lumen of a vein. And we'll find better examples of it as we tool around. But this is going to be one of the things that is so striking, is a very deadly form of cancer can look so benign, even when it's in a vein, of all things. So let's find another vascular invasion. And again, this subtle pattern, you can of course have the more standard vascular invasion that we've talked about, but this subtle pattern is so typical of pancreatic cancer. Again, here's another muscular vessel. Hopefully you can appreciate, and I'll hold steady here, that this is a muscularized vessel, and right in the center of it, you have replacing the endothelium. You no longer have endothelium here, it's lined instead by a single layer of well-differentiated ductal cells. In this case, it's a ductal adenocarcinoma. So vascular invasion, a common feature in pancreatic cancer, helps establish the diagnosis, can be a mimicker of a benign thing, can be a mimicker of a benign gland, but it's location, right? It's like real estate, location, location, location. Now, as you think about it, what makes pancreatic cancer so bad? And one thing could be this common venous invasion, which you see here, right? Where do lymphatics drain? Well, lymphatics will drain into lymph nodes. Where will muscular vessels drain? In this case, they'll drain into the liver. So liver metastases are a very common feature of pancreatic cancer. And one of the reasons may be this vascular invasion. I'm going to hold steady, hopefully, here on this. Another example looks kind of like a pancreatic intraepithelial neoplasia, right? Like a Panin lesion in another setting. But if you look carefully on the periphery of this, you see the media of the vessel. So this is vascular invasion, pancreatic cancer. And again, such a puzzler, I think, that here you have such a deadly form of cancer. It's invading into a blood vessel, and yet under the light microscope, an individual cell can be impossible to tell from a cancer from a benign gland. So first feature we identified, haphazard arrangement of the glands. The second feature, vascular invasion. And in pointing out vascular invasion, I highlighted this unusual form of vascular invasion that occurs in pancreatic cancer, and that's invasion into the vessels, the muscular vessels, as you can see here. And when it does, complete lining of the lumina, mimicking an entirely benign process. So a nice example here. The third feature I wanted to highlight is Perineal Invasion, is a common feature in pancreatic cancer. Perineal invasion can rarely, there are case reports of perineal invasion being identified in cases of chronic pancreatitis. This is an obvious case of pancreatic cancer, but perineal invasion is common in pancreatic cancer and is important to recognize because it can help establish the diagnosis. But because you can rarely see it in chronic pancreatitis, a single focus of perineal invasion in the wrong clinical setting, back off on calling it definitively cancer. But here's a nice example of perineal invasion. Perineal invasion in the pancreas has been associated with extension of the carcinoma out of the pancreas into the retroperitoneum, and associated in some clinical studies with pain. Pain is a common feature of pancreatic cancer, and in fact, Giovanni Battista Morgagni, the famous Italian anatomist in Padua, described one of the earliest cases of pancreatic cancer. The pain the patient was suffering is just as if he was being torn to pieces by dogs. And so the pain is a real clinical problem in patients with pancreatic cancer. Perineal invasion is commonly found, and some people have suggested the association of perineal invasion with the pain the patient has experienced. In addition, a common site of failure when they do a surgical resection of the pancreas, a Whipple, is the retroperitoneum. Where do these nerves go? Well, they go back into the retroperitoneum. So it's been hypothesized that the perineal invasion that you see here is kind of the highway out of town by which infiltrating ductal adenocarcinoma of the pancreas extends out of the pancreas into the peritoneum. The surgeon cuts, they think they've taken it all out, but there's still some neoplastic glands remaining in the perineural spaces in the retroperitoneum, explaining the high local recurrence rate that one sees often with ductal adenocarcinoma of the pancreas. So another helpful feature, perineal invasion. And I think I have another focus that I can show you. This one on frozen section. This was a frozen section, I think, of a margin that was taken. And right in the center was a nice example of perineal invasion. At low magnification, you can see much of the pancreas is not involved in this particular case. But like a bullseye right at the center, when we go down, we see a nerve with Perenara Invasion. In this case, the location of these glands, even though they lack significant atypia, helped establish on frozen section diagnosis that this is in fact infiltrating adenocarcinoma. Now, in this particular case, you can also start to see some atypical mitoses. So when you start to see atypical mitoses, that can be helpful. But again, as I showed you in that case of chronic pancreatitis, the presence of mitotic figures does not equate with ductal adenocarcinoma. So we've gone through the first three features: haphazard arrangement of glands, vascular invasion, and perineural invasion. Now let's continue down and see if we can identify more examples. And so the fourth feature we mentioned was luminal necrosis. And I think if you remember on that first case I showed you, there was beautiful luminal necrosis. Let me pull that up again. So the finding of luminal necrosis can be used to support the diagnosis of oops, that's the wrong slide. The finding of luminal necrosis can be used to support the diagnosis of pancreatic cancer. Here we go with the right slide. So here's a case at low power. I think you can appreciate there's a haphazard arrangement of glands. As we go around, one can begin to now see a number of the features that we talked about. And the two I'd like to emphasize with this particular case are the luminal necrosis. So you can see these dead epithelial cells in the center of the field, in the center of the lumina here. And then in addition, incomplete lumina. So here's a gland that you can see, and see how at one edge of it, now there are no epithelial cells. You've got the lumen touching naked stroma. So you've got two nice features here: luminal necrosis and incomplete lumina, both of which favor a diagnosis of pancreatic cancer. You can have intraluminal debris and chronic pancreatitis, intraluminal calculi, very common, and alcoholic chronic pancreatitis. But this true kind of individual cell necrosis, as you're seeing here with this luminal debris, a very typical feature of ductal adenocarcinoma. And if we sneak a little bit further south on this particular one, we're going to come to another feature that's very helpful, and we call it the 4-to-1 rule. So in a given gland, if you have a nucleus that's 4 times bigger than its neighbor, that's a very helpful feature for diagnosing adenocarcinoma. Now, often it's not present, and when it is present, most of the other features are also present. But it gives you something you can potentially hang your hat on, this so-called 4-to-1 rule. Again, it's in an individual gland. Variation in nuclear area greater than 4-to-1 supports the diagnosis of pancreatic cancer. And I'm sure all of you are picking up on the fact I'm not saying is diagnostic of. All of these features, I don't think there's one feature you can really hang your hat on and say it has this one feature and therefore it's ductal adenocarcinoma and not chronic pancreatitis. Instead, it's bringing everything together, the clinical, the imaging, with the microscopic findings, finding hopefully more than one feature, and all of them together fitting nicely into a picture that can help you establish the diagnosis of pancreatic cancer. Again, because it's such a critically important one. Let's look around this slide a little bit more for, again, the finding of incomplete lumina. See how the epithelial cells line this lumen and then all of a sudden they're gone here? The same here, incomplete lumina. And then over here in this corner, incomplete lumina. So really a nice case showing multiple different areas with luminal necrosis and incomplete lumina. So let's continue now with the 4-to-1 rule, the next feature that we discussed. And I've got this slide marked as showing the 4-to-1 rule. So let's see if we can identify what we mean by 4-to-1. So again, in a given gland, you want to look at the gland and identify nuclei that are 4 times larger in area, not diameter, than their neighbors. And you can see that here nicely where you've got these individual, very large nuclei shown in the center here. And maybe I can crank it up one magnification. And really nicely highlighting that 4-to-1 rule is present here. You have to obviously be careful if you've got perfectly round nuclei in a location where they don't belong. And right next door, just through the sectioning, remember we never see an entire section, we're getting 5-micron sections, a cutoff top of a nucleus, and don't say, oh, there's 4 to 1 with this one individual nucleus next to its neighbor. Look at the setting in which it's occurring. Consider the entire picture. Here, these are out in the stroma, obvious nuclear atypia. These are, and then there are multiple areas in which the 4 to 1 rule is met. So be careful with sectioning. Remember, each section has a thickness, 4 to 5 microns, depending on your lab. And each section, therefore, may not contain a complete cross-section of a nucleus. So don't mistake partial nuclei for a 4 to 1 rule. I'll continue wandering around this slide, and as we do, I'll try and stop on an area so you can appreciate more foci with this so-called 4 to 1 rule. Again, it's the area of the nucleus 4 times bigger than one of its neighbors, not the diameter. And you can see just huge nuclear variation here. So we've gone through haphazard glands, vascular invasion, perineural invasion, luminal necrosis, incomplete lumina, and the 4 to 1 rule. The next feature I want to talk about is a gland next to a muscular vessel. In order to do this, let's go back to our example of chronic pancreatitis and show how in the normal pancreas, and even when there's severe chronic pancreatitis, you don't see these glands next to muscular vessels. And that's, again, think of the grapes on a vine. As the grapes shrink into raisins, the stalks of the vine, if you will not touch the things that are in between the grapes. If that analogy works for you. So let's go back to our case of chronic pancreatitis just to refresh our memory. And we'll focus on what's the relationship of the ducts to the muscular vessels. And so here you can see a muscular vessel, and here you can see a lobular unit, another lobular unit. And as we go around, have a look and see how do the lobular units relate to the muscular vessels. So again, here's an example of a lobule, and there's the muscular vessel. And I'll hold still here. Sorry, there are a couple of pieces of dirt on this line. But you can see how those glands in that benign atrophic lobule are not anywhere near that muscular vessel, even in this very severe form of chronic pancreatitis. So the grapes are turning into raisins, shrinking away almost from the muscular vessels. So the finding of a gland next to a muscular vessel is an abnormal finding, suggests now a haphazard pattern of growth, that the cancer has broken through the normal architecture of the lobules into the stroma, and it's broken where it doesn't belong. Again, I'll continue to move around so you can get a sense of that, shown nicely here. Again, here's the duct, and look how far apart the muscular vessels are at the periphery of this. And really, everywhere we go, here's the muscular vessel at the periphery, right? Here's a lobule, muscular vessels at the periphery. So let's see if we can now find that feature in cases of pancreatic cancer. And so here are a couple of examples of that. Here's an example as we're looking for our gland next to the muscular vessel. Really nice example of perineural invasion, or almost intraneural invasion here, one of the earlier features we talked about. And look how it's really quite remarkable. If you took this gland or duct by itself, it'd be hard to say that's definitely carcinoma, not a reactive gland. But, oops, out of focus here, I'm sorry. But boy, yeah, it's in the wrong location, right in the middle of a nerve. So again, location is so critical in establishing the diagnosis. Well, let's see if we can find the finding of a gland next to a muscular vessel. And so here we are. Here's an example of a small vein, a venule. And there's a gland where it doesn't belong. Really easy to miss this gland if you weren't paying attention, right? But boy, it's in the wrong location. You can see it in the upper right-hand corner, the muscular vessel, the lower left, this relatively diminutive gland, minimal atypia, relatively round nuclei, but it's in the wrong location. And recently, my colleague here at Hopkins, Laura Wood, did a really elegant study in which she cleared sections, big chunks of human pancreata with pancreatic cancer in it, and then immunolabeled using fluorescent labeling for cytokeratin 19, and in 3 dimensions was able to show this isn't a random process. I always thought that this kind of was like throwing pepper on a slide. Occasionally, one of these glands will arrive next to a muscular vessel where it doesn't belong. And what Laura showed is, in fact, that the pancreatic cancer loves to grow in the perivascular space. And so if you have in 3 dimensions a pancreatic cancer, think of it as a crab, if you will, and there's a muscular vessel in the upper right, that crab will send out an extra long arm that will follow along that blood vessel for several millimeters. So perivascular invasion is not a manifestation simply of haphazard growth of pancreatic cancer, but there must be something about this perivascular location that pancreatic cancer likes. Perhaps it's one of these spaces that Neil Teese described recently in his paper, or perhaps there's a growth factor, but perivascular invasion, a very helpful feature, and it's not a random event. Let's find another example of this. Hopefully, as we're going and looking at these, you get the real sense that pancreatic cancer can be extremely well differentiated in a given gland or a given duct. In isolation, it can be impossible to tell, is this an example of pancreatic cancer or is it chronic pancreatitis? It's really the context, the location of these glands that helps identify or helps establish the diagnosis. So here's an example of a pancreas at low magnification. And we'll go look around and see if we can identify a gland next to a muscular vessel to help us establish the diagnosis. So right away at low magnification, we're noticing a haphazard arrangement of glands, right? They're going in different directions, as you can see here. I thought this one had one at the periphery. I won't spend too much time if we can't find it. Yeah, so look at this gland here. Boy, that looks pretty benign to me, doesn't it, to you? And it's in the wrong location. You can see here's the muscular vessel. I'll keep the condenser in. So take the condenser out, you may be able to appreciate the elastic lamina. Is that broadcast at all? You can see the elastic lamina in the vessel, and then you see this well-differentiated gland. So that's pancreatic cancer. They're round, uniform nuclei, but and we recognize it's in the wrong location. So a gland next to a muscular vessel, a very helpful feature in establishing the diagnosis of cancer of the pancreas.
Dr. Hruban, do you use that feature on frozen sections to help you?
So there's an excellent question from my colleague in the audience, whether you can use this on a frozen section to help, and absolutely. It's extremely useful. Again, you know, particularly on margins, one will notice, nice lobular arrangement of the glands, let's say at a pancreatic neck margin, and then you've got a muscular vessel and you've got a well-differentiated gland right next to it. That's probably pancreatic cancer. The surgeon should take more. So one of the very helpful features on frozen section, because all it requires you to do is identify where the muscular vessels are. Next, we occasionally use immunolabeling, and I don't want to give the impression that we use immunolabeling every day in diagnosing pancreatic cancer, but you can use it. And one that I love is SMAD4. It's a tumor suppressor gene previously called DPC4 for deleted in pancreas cancer locus 4. It's located on chromosome 18q, and it's homozygously deleted in about 30% of pancreatic cancers. And then it's inactivated with a point mutation coupled with a loss of the second allele and another 25%. Regardless of the mechanism of inactivation, in about 50% of pancreatic cancers, you see complete loss of immunolabeling for the SMAD4 gene product. And so here you can see really a nice example of that in the background stromal cells, beautifully, strongly labeled for SMAD4, and you can see complete loss of SMAD4 in the infiltrating ductal adenocarcinoma cells. Again, it's not something we use day to day. It's usually, I'm 99% sure this is pancreatic cancer. I have to convince my colleague and so you do the immunostain, and it comes out often, as you can see here. Key thing to remember, 45% of pancreatic cancers don't show loss of SMAD4. So you can't use intact SMAD4 labeling to say that it's not pancreatic cancer. And when you do see loss, it's complete loss, as shown here. And I'll show you a couple more examples. And it's not a subtle shade of gray. It's black and white. It's like holding a chest X-ray up where things are black and white, and you can see them, as you can see in this particular case. Let me show you another example of loss of SMAD4 immunolabeling. Again, low power, you can see the normal pancreas, nice labeling of all the glands. And then if we go over here, the cancer's invading into the bile duct, so we have a nice internal control. And I'll go to higher magnification. So here you can see on the right a gland of infiltrating ductal adenocarcinoma. The nuclear atypia is quite obvious. And on the left, a benign gland here of around the bile duct. Notice the nuclear labeling, so it's not just a nonspecific blush in the normal or non-neoplastic cells. You have that really nice nuclear labeling, positive expression. And look, notice the complete absence of expression in the infiltrating ductal adenocarcinoma on the right. So it's not something subtle. If it's shades of gray, don't call it SMAD4 loss. So SMAD4 loss, our 8th feature. So to recap briefly at this point, and then I'm going to show a couple mimickers, if you will, the features that we use: haphazard arrangement of glands. Think of the grapes on the vine. Vascular invasion, and remember that this is often muscularized vessels, and you have this paradoxical maturation of the epithelial cells. So in areas of vascular invasion, it can mimic a normal gland. And remember that the muscularized vessels are going to drain into the liver. This may explain part of the very poor prognosis of pancreatic cancer. Perenara Invasion, the highway out of town. Luminal necrosis and incomplete lumina, they tend to go together. The 4-to-1 rule, very useful, but remember, be careful you're not just looking at a partially sectioned nucleus. Gland next to a muscular vessel, which I've illustrated, and remember, this isn't a random process, but rather pancreatic cancer loves to grow in that perivascular space for some reason, and SMAD4 loss. So those are the 8 features, and now let's look at a couple things I think it'd be worthwhile to look at, and then I'll show a couple unknowns and open it up to questions. So here's an example of treated cancer, and I wanted to show a treated cancer. It's just because more and more patients are receiving neoadjuvant therapy, and it's important that we can recognize treated pancreatic cancer. One can here see a benign gland, very disrupted, you can appreciate the inflammation, the fibrosis in this gland here. But as we look around more carefully, we can identify some areas in which they're treated cancer. In this particular case, we can see where there once was cancer. So to the right, you have your muscularized vessel, and to the left, a acellular pool of mucin. So presumably this was cancer in a perivascular space that's been successfully treated, and obviously you wouldn't call that residual cancer. It may also be right next to a nerve there. But as we look here now is an example, and we'll see probably, I think, better examples, where you can see really dramatic nuclear atypia in some of the glands, invasive glands of treated cancer. Let me see if I can find a better example than that. Let me see. Here's some, but you end up with very large nuclei after treatment. They're really quite enormous, gigantic nuclei. Somewhere on this slide, there are even better examples. And maybe we'll come back and look for it. But I want to illustrate one that don't call acellular pools of mucin residual cancer. That's where the cancer once was. And then these very large atypical nuclei that can be present. Oh, here we go. Here's, I guess I should look where the dot is. Here you can see some of these very, very large hyperchromatic nuclei. And these are the treated neoplastic cells. And there's another one in here. And there are different systems for scoring the response to treatment. And here we go. There's the guy I was looking for. There are different ways of scoring the response to treatment. And basically, the fewer neoplastic glands that remain after treatment, the better the patient's prognosis. It's not perfect. You can have complete histologic response, and yet some patients will die. And you have other examples with a less effective response and the patients live. But nonetheless, it's important to attempt to quantify or grade the degree of response after treatment. Another real mimicker that can throw people off is called cancerization of a duct, of a gland. And this is a common finding in pancreatic cancer. Just as pancreatic cancer likes to grow in the vessels, as I showed you, it likes to grow in pre-existing ducts and can extend quite a ways down them. And you can, I'll show you a couple examples here. So this is a duct that's in the center of a lobule. You say, oh, it's got to be benign. But in fact, this is invasive cancer that has grown from the stroma down here into the duct, and then it extends, and it can extend for quite a distance along the duct system. And one can appreciate quickly, there's really dramatic atypia, there are mitoses here, there's necrosis. Many of the features we talked about, the 4-to-1 rule, are present here in this gland. It's in a normal location, right at the center of a lobule, as you can see, but this is cancer growing in a pre-existing gland called cancerization of a duct. And you can see one of the features that's very helpful. Here it's grown into a much bigger duct or gland. And on the right side, you can see this dramatic atypia. On the left side, a low-grade atypia. It's the abrupt transition from normal to abnormal that is a clue to the diagnosis of cancerization of the ducts. And so here we can see that. Again, at the top, relatively normal ductal epithelial cells, and then all of a sudden, this very dramatic atypia with bizarre mitoses, necrosis, and so on. So an abrupt transition from normal epithelium to high-grade dysplasia in the pancreatic duct raises the possibility of cancerization of a duct. The other feature would obviously be if there's an adjacent invasive cancer. I love this diagnosis because it gets the biggest laugh out of the surgeons when you tell them that there's cancerization of a duct at the margin, take more. And I stopped doing it because they, for whatever reason, find it very humorous. So we just say invasive cancer is present. But this may be one of the reasons for recurrence of pancreatic cancer in the remnant pancreas after surgery. This can be underappreciated. The cancer can grow a distance from the primary mass, and if it grows in the adjacent pancreas, the pathologist interprets this as Panin, pancreatic intraepithelial neoplasia, and not what it is, truly invasive cancer. And then we're all surprised when this recurs later. We've seen rare cases where we've gotten a resection and all we have is cancerization of the ducts. And this is a very difficult situation, completely embedded the pancreas, multiple deeper sections. And we went back to our surgical colleagues and said, we think that the main mass is in the remnant pancreas. And the surgeon has gone back and completed the pancreas resection and found a subtle invasive cancer that was missed. And so what was taken out was just the cancerization of the ducts. So cancerization of the ducts can be a real mimicker of Panin, of a benign process. But this is invasive cancer growing along a pre-existing duct structure. Let me show you another example of that here. This one I think may be on frozen section. Yeah, and this is a frozen section. And there were some clues here. Here's a duct. It's a little bit hard to see what's going on there, but clearly quite a bit of atypia present. And when we look around, there's some clues, in fact, that that's what this was. where one can identify abrupt transitions. I won't take the time now, but that abrupt transition between benign epithelium in the duct and this really dramatic atypia was a clue to the diagnosis. So cancerization of a duct is something to be aware of. We briefly mentioned Panin lesions. These are non-invasive precursor lesions in the pancreas, pancreatic interepithelial neoplasia. And I thought just for completeness, it'd be useful to show one. Here at low magnification, one can appreciate the Panin lesion here. This is a low-grade Panin lesion. They're often associated with areas where presumably they're causing upstream fibrosis and inflammation, a process called lobular atrophy. But if we look at low magnification, again, you see the pattern isn't violated. These aren't haphazard glands. The muscular vessels are out here. Instead, this is a benign precursor lesion. Pancreatic interepithelial neoplasia has no clinical significance. Cancerization of the duct, big clinical significance. Panin lesions, no clinical significance. And so a very important distinction. And if we go to higher power, you see how uniform the atypia is. We don't have that abrupt cutoff as we saw with cancerization of the ducts. Finally, something you saw a glimpse of earlier, pancreatic cancer loves to invade into adjacent organs. And so here's an example of pancreatic cancer invading the duodenum, and obviously the glands where they don't belong. So here you can see the duodenum, Brunner glands, and as we go deeper, the muscularis propria of the duodenum. And one can appreciate these invasive glands coursing between the muscle fibers. And this is, I think, perhaps parallels what we see in the perivascular space, where here you can see the muscle fibers running this way, and sure enough, that's the path that the cancers are following, perhaps in these little spaces between the muscle fibers, as you can see here. So duodenal invasion, obviously a helpful feature in establishing a diagnosis of cancer of the pancreas. And again, let's go to higher magnification, because I just find this, sorry to beat a dead horse, but it just is just amazing. Here we are in the duodenum, and look how little atypia there is for these glands. One of the deadliest of all human solid malignancies. And boy, these glands look remarkably benign. So that's a quick rundown of the criteria. And I thought one thing that would be helpful now is to give you guys some unknowns. And feel free to tweet them if you want, but also just write them down on a piece of paper and see how much we've all learned. So here's an unknown, and let's have a look and see how we would classify it. And I'll try to be relatively quiet as we go. And Rafat has told me don't move the slide around so much, so I'll try not to. So hopefully everyone's had a chance to look at it. I've intentionally kept it at low power because the goal here is it's all location, location, location. Much of what I showed you at the beginning was just chronic pancreatitis with Panin lesions. But those of you who are, I'm sure you noticed here in the upper right, muscular vessels, and what's in the muscular vessel, there's a gland in the middle of a muscular vessel. So a really nice contrast. The lower left and bottom, Panin lesions, the upper right, invasive adenocarcinoma in a muscular vessel. Well, it doesn't belong. Let's go to a little bit higher power here now that you guys have seen that. And again, really a very helpful feature, but boy, hard to tell that gland from a chronic pancreatitis other than it's in the middle of a vein, right? And it completely lines the circumference of this vein, which is quite remarkable. And where does this vein drain? Into the liver. So a nice example of vascular invasion providing a clue to the diagnosis. All right, here's another one. And again, feel free to write down your diagnosis, and I'll try and keep it at relatively low magnification and maybe zoom in a little bit where I can. So this is a hard one. And you can see in areas it's pretty easy, right? A nice lobular atrophy, the muscular vessel at the periphery, but things start to break down a little bit. This is an example of chronic pancreatitis, but one in which the glands start to get near muscular vessels. And even though they're near a muscular vessel, and we can see it here, and then there was another location up here, what you notice that the glands, they get close to the muscular vessel, but they still have a lobular arrangement, right? The glands that are close to the vessel still are forming a lobular unit. And so this is getting close to that feature, gland next to a muscular vessel. But in this case, the fact that these glands at low magnification are forming a lobular unit, and you can see there's a little connective tissue plane. If you see how the lobular unit is here, and then there's a little connective tissue plane between the muscular vessel and the glands. And so this is a very helpful feature, and it prevents you from not overcalling this example of chronic pancreatitis as an example of pancreatic cancer. Let's try another one. So this is a hard one. This is one, the first thing I showed you was a Panin lesion, a nice uniform cells in a gland where they belong. The second gland, what one notices dramatic atypia, and sorry for the fold here, but you have very dramatic epithelial atypia, and then an abrupt transition to completely normal epithelium. And so this is an example of cancerization of a duct. And so in this case, it would be invasive ductal adenocarcinoma, and it's this abrupt transition that you can see here. And again, I apologize for the fold to these atypia, the atypia that you see there. All right, let's do another, and then I want to leave 10 minutes at the end for your questions. So please send in your questions. What do you guys think of this guy? Right, so you get absolutely right. So you can see a muscular vessel coursing from left to right or right to left here. And then you've got these glands here in the perivascular stroma where they don't belong. So this is an example of a gland next to a muscular vessel. It's not part of a normal lobular unit. So this is invasive ductal adenocarcinoma, and it's the gland next to the muscular vessel that gives it away. And one last one, the bonus point here. A nice normal lobular architecture, really a nice example. See the vessel running at the periphery here, away from the glands? Please feel free to stop me when you think you have a diagnostic feature. Nice lobular architecture to the glands, right? All right, so Rafat is saying, wait a second, look at the corner. And sure enough, this was all that was on this slide, I think. You can see a muscular vessel, right? In this case, there's the artery, there's the vein, and you've got this gland in it, and this is invasive adenocarcinoma in a vascular space, and call this margin positive. Great. All right, so quick whirlwind tour of the 8 features we use to distinguish reactive glands of chronic pancreatitis from invasive ductal adenocarcinoma. You remember there are the haphazard arrangement of glands, vascular invasion, and we highlighted how benign looking the vascular invasion can be and its potential clinical importance going to the liver. Perineal invasion, a very useful feature. Occasional rare case reports of perineal invasion and chronic pancreatitis, so be careful with that. Luminal necrosis and incomplete lumina, the two features that go together. The 4-to-1 rule, very helpful. Remember, it's 4 times variation in nuclear size in the nuclei in a given gland, and a gland next to a muscular vessel, one of my favorite features. And then finally, we can use adjunct tests such as immunohistochemical labeling for SMAD4. And when you see loss of SMAD4, as I showed you, that can be supportive of the diagnosis. Remember, intact SMAD4 occurs in 45% of pancreatic cancers, and so you can't use it in that sense. So thank you. And now Rafat and Emilio, I'd open it up to questions from the audience.
Thank you, Dr. Hruban. So I would like to let you know that, and you'll be happy to know also that we have viewers from so many different parts of the world. We have viewers from Egypt, Brazil, India, Finland, Romania, Somaliland, Algeria, Morocco, Iraq, Italy, Colombia, Uzbekistan, Turkey, Japan, and of course from US. So we have a few questions, so I will read them to you. And thank you again, Dr. Hruban. So Alex is asking, so these features are helpful in surgical specimens, or also they are helpful in biopsies as well?
Alex, great question. Are these just helpful in surgical specimens, or can they be used in biopsies? Absolutely, both in biopsies and in surgical specimens. Obviously, in biopsies, you get a much smaller sampling, and so some of the architectural features can be a little bit harder to appreciate. But we use exactly the same in surgically resected specimens as we do in biopsies. Great question, Alex. Thank you.
Ifat Jamal is asking, so won't this vascular invasion will thus be called an LVI, or this is part of a diagnostic feature?
So a great question. Would this also be called LVI, or is this part of it? So LVI meaning lymphovascular invasion, a much broader term, and absolutely any lymphovascular invasion is abnormal and suggestive of cancer. What I wanted to highlight is within the larger lymphovascular invasion, which I think we're all familiar with in any organ, there's a unique aspect to lymphovascular invasion in pancreatic cancer, and that's the invasion of muscular vessels, the venules, and the growth along the venules, inside of the venules. And when it does, the complete lining of the lumen, and those cells look so well differentiated that it can be a real mimicker of a benign process until you recognize it's in the vessel. Great question.
So Geronimo is asking from Brazil. So his question is that, do you have any pitfall alert for diagnosing on US FNA cases?
Geronimo, thank you for that question. I don't do cytology. Our colleagues here, Sayed Ali, and a group in cytopathology do them. We do have a free, I don't mean to advertise something, it's free, I'm not trying to sell anything, iPad app on pancreatic cytopathology that you're welcome to download. But my personal experience, I don't do cytopathology, so I don't feel comfortable answering that question.
So he also has another question that, what are your criteria for differentiating cancerization of the duct from high-grade panin?
Great. So, Geronimo, thank you again for another good question. What are the criteria to distinguish high-grade panin from cancerization of a duct? And this is something one of our residents did, Danielle Hutchins, I don't know if she's still here, and highlights there are two features that are useful. One is the close association in the same slide of the invasive cancer with the duct in question. And second is that abrupt transition that I showed you. Normally panin, it's a very subtle change, kind of different shades of gray. But when you have cancerization of the duct, the cancer grows in, it's markedly atypical, there's normal epithelium there, and you have a very black and white distinction between normal and abnormal. In some cases, you can also do immuno labeling. So if you're immunolabeled for SMAD4 or P53, those abnormal markers would support the diagnosis of an invasive cancer, because those tend to be late genetic events occurring typically when there's an invasive cancer, although not always. They're not perfect markers. The important thing is to be aware of it and not to overcall panin on a margin, because remember that has no clinical significance. But boy, be aware of cancerization of a duct on a margin, because that does have clinical significance. That's equivalent to an invasive cancer being present at the margin. So a critically important distinction.
Yeah, Kalyani has a question. She's from India right now. So asks, do precursor lesions also show SMAD4 loss?
Great question. Do precursor lesions also show SMAD4 loss? Um, uh, we used to think they did. And before we began to recognize cancerization of the duct, many things that are now recognized as cancerization of the duct, we would call high-grade Panins or Panin 3. And so when we first developed our progression model, we had SMAD4 loss as occurring in the high-grade dysplasia or the Panin 3 lesions. But that's because we were mistaking cancerization of the duct from Panin 3. I think when you're careful and you exclude Panin cancerization of the duct, SMAD4 is really is probably occurring at the invasive state. But because of this, the literature is mixed when you go, and most of the SMAD4 loss in precursor lesions is in fact misdiagnosed cancerization of the ducts.
Here's another question. Mohammed has a question for you. Any new immunomarkers for detecting metastatic pancreatic adenocarcinoma?
Mohammed, great question. Any new immunomarkers for detecting metastatic pancreatic cancers? There have been a number of approaches of gene expression, starting in the early days of SAGE, serial gene analysis of gene expression, to microarrays, to now a much broader sequencing methods. Typically, we tend to use SMAD4 as suggestive of pancreatic cancer origin, but remember, metastatic colon cancer, 15% can show SMAD4 loss, so it's not a perfect marker. Mesothelin is typically highly expressed, but there isn't a great marker for pancreatic origin currently available.
There's one more question, and Nguyen from Japan. So he has this question: do desmoplastic stroma with fibroblast help in the diagnosis?
Another great question. So does desmoplastic stroma help in the diagnosis? And unfortunately, not so much. I think I showed you in some of those cases of chronic pancreatitis that dense fibrotic stroma. So I tend not to focus so much on the stromal reaction, but rather the architecture of the glands and at higher power, the morphology of the glands and the nuclei. Tend not to look at the stroma because, again, from that first slide, if you remember that very dense stroma of chronic pancreatitis, stromal fibrosis can occur and can be quite extensive with chronic pancreatitis. And chronic pancreatitis is pretty common.
That's all we have.
Great. Well, thank you all so much for joining us, and please keep an eye out for Rifat and Emilio. They're wonderful pathcasts, and we'll try and announce them through our website if you want to sign up and get the emails. But thank you, Rifat and Emilio, for including me.
Thank you very much, Dr. Hruban, for that thorough overview of pancreatic carcinoma and beautifully highlighting the potential pitfalls and those problematic mimickers that I'm sure all of our surgical pathology colleagues will greatly appreciate. I just want to mention that up next we will host Dr. Elizabeth Thompson on the 25th of April, and that's going to be at noon, and she will present her talk titled Cystic Lesions of the Pancreas. And I want to remind our audience that today's lecture can be found at pathologycast.com and our social networking websites. And we hope you enjoyed today's Pathcast. Until next time, thank you.